Hi, welcome. We're here to talk about the use of medical options in the management of RSV infection. RSV is the enveloped RNA virus, which is the most common cause of respiratory tract infections among infants and young children. RSV is a leading cause of infant hospitalization. Among payers, RSV is ranked highest among their most important concerns. Palivizumab is the prophylactic treatment of choice for patients at risk for RSV. It acts by binding to the F fusion protein of RSV, reducing viral replication and spread. Palivizumab has shown to reduce hospitalization. Shown here is a placebo-controlled study showing that palivizumab reduced hospitalization by 10%. Despite its efficacy in controlling infection, palivizumab has a high cost per injection. Its AWP is close to 800, and most patients need 5 injections. Therefore, most managed care entities use various management strategies to control the costs associated with palivizumab use, with prior authorization as its most popular strategy according to the Biotechnology Monitor. This presentation addresses how the Medopi solution may serve as an alternative to existing cost management strategies. The Medopi solution puts the risk of hospitalization as well as the reward for good outcomes in the hands of the deciding clinician in the care of the patient. Therefore, we will show how the Medopi solution capitalizes on a clinician's local knowledge, how it rewards for preventative measures and interventions, and how it encourages healthy competition between providers. What is Medopi? Medopi stands for Medical Options Product Insurance. It's a new way of thinking about healthcare, such that the medical providers may buy and sell insurance between each other through medical options contracts. A medical options contract confers the right, but not the obligation, to purchase a representative product or service at a guaranteed price for a period until expiration. We know from Strand et al. That if we had 100 patients at risk for hospitalization, without prophylaxis would result in 25 hospitalized patients. Yet, we can prophylax with palivizumab and block up to 2 patients from hospitalization. What would be the cost of treating these patients? The same retrospective review found that with palivizumab treatment at $3,000 per patient, this would total $300,000. Preventing all but 2 patients from hospitalizations at $4,000, a patient costs $8,000. Spreading this over the population yields a result that it really isn't cost effective. Yet what we really are dealing with is the opportunity for a physician to sell this contract to expecting patients who are unknowledgeable of their child's RSV risk or status. AAP guidelines state that preterm labor is a risk factor for RSV, warranting prophylactic therapy. Therefore, the question is, out of 100 pregnancies, how many are at risk for RSV through preterm labor? This is where the clinician capitalizes on the local knowledge of their patient population. Suppose they know that out of 100 pregnancies, they could expect 12 preterm births, warranting palivizumab therapy, yet with 1 likely treatment failure leading to hospitalization. We know from the Strand et al. That hospitalization costs $4,000. Also at $3,000 per patient for palivizumab therapy, we total $36,000, yielding a final total of $40,000. We can spread this over the entire 100 patients to yield $400 per patient that the clinician could charge the health plan. If there is less patients at risk than predicted or leading to hospitalization, the clinician earns a higher cash flow than expected. The opportunity for the clinician to write their own authorization for palivizumab use encourages capitalizing on the unique knowledge of their patient population. Also, the incentive for cash flow encourages preventive measures, shown in the following slide. We know that preterm labor and RSV infection have modifiable risk factors, notably smoking and environmental status. Because a physician earns a higher cash flow from better outcomes than anticipated prior to contract writing, there's an incentive to intervene on these preventative measures. There is also an encouragement of healthy competition between providers. Suppose again we have a provider who expects 12 preterm births and 1 hospitalization. Let's let her compete with yet another similar provider who expects more preterm births and has a higher RSV hospitalization liability with their medical options contract. We can expect, therefore, the latter provider costs the health plan more than the former and is less competitive. In conclusion, Medopi, Medical Options Product Insurance, allows a clinician to write their own terms for health technology utilization, and capitalizes on the local knowledge of their unique patient population. We see the inherent possibility for rewards on preventative interventions, as well as the encouragement of competition between providers. To learn more about medical options product insurance, visit medopi.com. That's MEDOPI.com. Thank you for your time.